With the 2012 budget proposal that grants physicians a 2-year reprieve on the cuts mandated by Medicare's SGR formula, the possibility for real medical liability reform, and heated battles on the Affordable Care Act in the offing, MedPage Today asked Health and Human Services Secretary Kathleen Sebelius to sit down with us for a discussion of the key issues facing the federal government and healthcare providers today. Secretary Sebelius met with Emily Walker and me, Joyce Frieden, at the Department of Health and Human Services. Executive Editor Peggy Peck joined us by phone. Secretary Sebelius, thanks for sitting down with us today.
Sure.
I wanted to start out by asking about the budget proposal, and in particular about the proposal to have a 2-year fix for the sustainable growth rate in Medicare. And I was wondering why you decided to go for the 2-year fix instead of a permanent fix.
Well, I think it's a question of working with Congress to come up with resources for a long-term strategy. The president has said really from the beginning of his administration that this year-by-year kind of kick-the-can approach to SGR doesn't work for patients, doesn't work for doctors, isn't good for the Medicare compact. And so he wanted to start with a proposal that, you know, put money in the budget, and actually there's more than 2 years. There's about a little under 2.5 years worth of offsets to start with, and it really kind of starts the conversation. We're hopeful that Congress will pass this, which would be, frankly, the longest SGR fix in a while, and then immediately come back to the table and work with us on what is a permanent fix.
Right, because doesn't the fix get more expensive as time goes on?
Well, it does if you don't address it. Yeah, the numbers just get bigger. But I think in the context of looking at overall Medicare, how we make it solvent into the future, there can't be anything more important than making sure we have doctors. Doctors are getting a little weary of year by year having their pay jeopardized and saying, you know, I'm not sure I want to be part of this system anymore. So it's essential to the 47 million Medicare beneficiaries, more joining every day with the baby boomers. You know, the first year of baby boomers turned 65 this year. So we have now the biggest group coming into Medicare a year at a time to fix this long term.
And speaking of the fix, one of the provisions to pay for the fix had to do with penalties for doctors who aren't using electronic health records. And I wanted to ask about that because it seems like a double-edged sword. On the one hand, that's giving you money to pay for the fix, but on the other hand, it's hurting the doctors who aren't able or aren't willing to do that. So I wanted to ask how you justified that sort of strategy.
Well, I think that the bulk of the fix is really there's a major fraud and abuse effort that we think will pay big dividends, and that is over half of this 2+ years of pay-fors. There are some elements dealing with the pharmaceutical companies. I think what you're referring to is capturing what was already in the bill, where the HITECH Act actually has incentives for a while, right, and then eventually disincentives, because what we want to do is get every healthcare provider basically using an electronic medical record, not for the healthcare provider, but so patients will have access to their own health information and be able to use it to make determinations, and those will be then part of the the reverse incentives. The incentives work for a while, and then we want to say there's a penalty to stay with paper records.
Well, that brings up the question when you mentioned the other pay-fors. What was the thought process in developing those? Like, how did you decide? A lot of it does seem to be coming from the pharmaceutical industry. So how does that work?
Well, again, that is about 1/4 of the money. I think the president feels very strongly that there's a balance, that the innovators and entrepreneurs who are in the pharmaceutical industry certainly need to recover their investment, need to be able to make a profit. We certainly want to encourage new drugs, new cutting-edge cures. On the other hand, the longer that patents are protected beyond the investment recovery and the profit share, makes healthcare costs for everyone go up, and often makes life-saving drugs unavailable for consumers who can't afford them. So there's got to be a balance. This says 7 years of a patent for a follow-on biologic, and that it probably isn't a good policy at all to pay generic makers not to go ahead and develop generic drugs. So I think those two are really balances of not only making sure in 7 years you can recover your investment, have the drug on the market, but also have it available for others to be able to take advantage of what is medical science at its best.
Emily?
Great. I'd like to ask you a little bit about the Affordable Care Act implementation. What specifically are you hearing from doctors on the ground, both the good and the bad, aside from the 1099 provision, which I know is not too popular with doctors?
Well, I hear a lot of kind of excitement about the possibilities of the new care strategies, kind of the delivery system reforms, being part of accountable care organizations, and being part of a bundled care strategy. Certainly the medical home model is something that a lot of doctors have talked to me about, being the way care should be delivered, but it was always difficult to get reimbursed effectively for strategies that actually keep people well in the first place. I'm really hopeful that part of the new tools we have in the Affordable Care Act actually can return medical practices to physician-centered initiatives where electronic medical record will give particularly primary care doc and gerontologists and others a way to coordinate care that's very difficult to do right now if you don't have the right records at the right time. Be able to follow up on a patient, be able to really monitor the care delivery, things that docs would like to do to keep people well and not wait until they show up at the hospital and you treat the acute illness.
Is there a specific part of the law that you're hearing doctors are especially concerned about having to comply with?
Well, I think there's still a lot of uncertainty about what it means. Certainly I hear a lot about the SGR, the Sustainable Growth Rate, and what that means long-term to Medicare. I think there's concern about what new rules may or may not affect them and how health plans may or may not affect. I think there's a concern that the accountable care organizations could become totally hospital-dominated and somehow require physicians to give up small practices or give up independent practices. And I just want to assure folks that that is not the intent. We think that the kind of accountable care organization, we'd like to see a lot of different models of innovation and care delivery. We think a number of them should be provider-driven, not even connected to hospitals, and look forward to an opportunity. I think as some of these initiatives get underway, some of the myths will be dispelled about what people are speculating they are or are not going to be.
Well, speaking of the myths, some would say that the kind of message to sell the ACA to the American people hasn't gone over so well. Do you have any ideas of how to remarket it to the American people, or what are your thoughts on that?
Well, again, I do think that as people begin to connect with the benefits, as you all know, health care is very personal. And while people may have some interest in the big philosophy, what they really want to know is what happens to me, what happens to my family, how does this affect me, what happens to my doctor. And the more that the law is implemented, the more those benefits begin to connect with folks. I'm seeing a real turnaround in people's attitudes. So parents of college kids definitely know that the law included a benefit to keep their adult children on their plan, and find that to be very good news and very practical news. I think small business owners who are beginning to take advantage of the tax credits. And I find with a lot of providers who I talk to a great deal of enthusiasm because they think the current system is broken. They think that, getting paid certainly through the government plans only when you do procedures or do tests is really not a framework that encourages great care, encourages great innovation. So there's a lot of little trepidation, not knowing exactly how this is going to play out, but I think a lot of excitement knowing that the current system was really broken.
The political climate right now is all about controlling costs. That's a big part of the ACA also. What can HHS really do, though, to make sure that insurers aren't raising premiums too high, given that HHS doesn't have any real authority to say you can't raise these premiums? They can just review them.
Well, actually, I think, again, the Affordable Care Act has two really important tools. One is we were able to give resources to state insurance departments where the regulation takes place to encourage them to really beef up their regulatory process, hire actuaries, get independent look at what the underlying trends are in the rates, have a process in place for hearings and input. But also the new medical loss ratio, I think, is an important piece of the puzzle. So for the first time, there's a formula that says insurance companies have to make sure that 80 cents of the dollar for individual or small group plans or 85 cents of the dollar of large group plans have to be dedicated to health costs and not CEO salaries, not marketing, not overhead costs. And if they don't, they actually owe a rebate to their policyholders. Those two pieces put together can be some very powerful tools. And I would say the third tool, which is pretty simple but works, I've seen it work as an insurance commissioner, is just a website that lines up the prices side by side, that somebody can type in a zip code and pull up for the first time ever what's available to them in their market, what the prices are, and compare them. That kind of bright light begins to change company behavior.
We're about out of time, but I wanted to ask Peggy, who's on the line from Ohio, if she had any questions.
I have. I know that we are really pressing the time limit here, and I want to thank you. I have a question just about this concept of subsidizing insurance premium costs so that we can expand coverage. But my big question is, what happens if you run out of money for that subsidy? Do you have a plan B?
Well, there isn't, Peggy, in the bill, a kind of fixed cap on how much money will be available. I think the goal in the long term is to make insurance affordable for those folks who are below 400% of poverty, to create, first of all, a more cost-effective marketplace, but then help provide some assistance to purchase that coverage for those who don't have employer-based coverage, who don't have an opportunity to buy in at that point, and recognizing that right now the trade-off will be that we won't any longer be providing billions of dollars of the so-called uncompensated care, people who can't pay their bills in a doctor's office, in a hospital, in an emergency room. So that care is being shifted onto taxpayers right now. And everybody with an insurance policy, on average, pays about $1,000 more than they would if there was no one with uncompensated care. So we're paying for it. What we're going to do is distribute those costs a little more in a straightforward way up front, and hopefully, in the long run, lower costs for everybody. So families who have a family insurance policy right now will see their rates go down just because there won't be so many neighbors and friends accessing care without any kind of insurance coverage.
Well, thank you very much, Secretary Sebelius.
Yes, great to visit with all of you. And Peggy, nice to visit with you.